Hey everyone, so today we are going to be talking about liver failure, which is the most severe clinical consequence of liver diseases. It occurs primarily in three clinical scenarios, which are acute, chronic, and acute on chronic. Okay, so first let's talk about acute liver failure, which is defined as an acute liver illness that produces hepatic encephalopathy within 6 months of the initial diagnosis. So that's why it is known as acute. In the United States, accidental or deliberate ingestion of acetaminophen accounts for almost 50% cases of acute liver failure, while other causes are autoimmune hepatitis, drugs and toxins, and acute hepatitis A and B. Now, in Asia, acute hepatitis B and E are the major cause of acute liver failure. So this could be asked the causes of acute liver failure. In Asia, it's not predominantly acetaminophen, whereas in US, this is the one. Okay, so if we talk about the morphological changes in liver in case of acute liver failure, now the main feature is massive hepatic necrosis. Okay, and the liver is very small in size and shrunken due to loss of the liver parenchyma, and microscopically there are large zones of destruction surrounding occasional islands of regenerating hepatocytes, and scarring is mostly absent because it is acute. Okay, so we can see over here the morphological changes in case of acute liver failure. So we can see that the liver has become shrunken and small, and there are areas of necrosis in here. In the photomicrograph also we can see the area of necrosis, and surrounding this we can see the normal hepatocytes. So this is what happens grossly and microscopically. If we talk about the clinical features, the liver failure manifests as nausea, vomiting, jaundice, and fatigue, which is followed by the onset of life-threatening encephalopathy, coagulation defects, and portal hypertension associated with ascites. Typically, the transaminase level in the serum are elevated into thousands. Okay, so the liver is initially enlarged by swelling and edema due to inflammation, but then the parenchyma is destroyed, and then the liver shrinks dramatically. Eventually, the hepatocytes are lost and serum transaminase values level off and then decline because their source also disappears. Okay. Now, worsening jaundice, coagulopathy, and encephalopathy develop with unabated progression. Multi-organ failure ensues and potentially results in the death of the patient. Okay. So the manifestations include jaundice and icterus, which is yellow discoloration of the skin and sclera, and due to retention of bilirubin, cholestasis due to systemic retention of bilirubin as well as other solutes eliminated in the bile. Next is the hepatic encephalopathy with symptoms ranging from soluble behavioral abnormalities to confusion, stupor, coma, and death of the patient. Hepatic encephalopathy is believed to be caused by elevated ammonia levels, which correlate with impaired neuronal function and cerebral edema. Okay, so where this ammonia is coming from? The principal source of ammonia is the GI tract, okay, where it is produced by microorganisms and by enterocytes during glutamine metabolism. Normally what happens is this ammonia is transported into the portal vein to the liver, where it is metabolized in the urea cycle. But in severe liver disease, this detoxification mechanism, it fails, and thus the ammonia will enter the systemic circulation. So this is the reason, and when it reaches the CNS, it impairs neuronal function and causes cerebral edema. So a typical neurological sign is asterixis, which is a non-rhythmic rapid extension flexion movement of the head and extremities, best seen as flapping of hands when the arms are held in extension and dorsiflexed wrist. So this sign can be elicited by the patient. We can check for it, and this is the worst case scenario. Okay, so next up is, apart from jaundice and hepatic encephalopathy, we have the coagulopathy. What happens is the liver produces coagulation factors whose level decline in case of liver failure, leading to easy bruising and bleeding. Paradoxically, DIC which is disseminated intravascular coagulation, may also occur in failure due to damaged liver to remove activated coagulation factors. So if more coagulation factors are also elevated, that is also a problem. It can cause DIC. And if coagulation factors are less, their levels decline, as in case of liver failure, they can lead to bruising and bleeding. Now next up is the portal hypertension, which arises when there is diminished flow through the portal venous system, which may occur because of the obstruction of the prehepatic, intrahepatic or posthepatic level. While it can occur in acute liver failure, portal hypertension is more commonly seen in chronic liver failure, and we'll discuss it later. So in acute liver failure, the obstruction is usually intrahepatic, okay, and it is its major clinical consequences are ascites and hepatic encephalopathy. In chronic liver disease, portal hypertension develops over months to years, and its effects are more complex and widespread. Next up we have is the hepatorenal syndrome, which is a form of renal failure occurring in individuals with acute or even chronic liver failure in whom there is no intrinsic renal pathology to account for renal dysfunctions. Means it's solely happening because of liver failure. The renal function initially had no problem, it was very much normal, but due to liver failure, if it is causing renal failure, then we term is that hepatorenal syndrome. Okay, liver failure results in the production of vasodilators such as nitric oxide, which increases the blood flow in abdominal viscera and consequent decrease renal perfusion pressure and reduce glomerular infiltration rate. In response to renal hypotension, the renal sympathetic nervous system is activated, as is the renin-angiotensin axis, both of which cause vasoconstriction of the efferent renal arterioles, further decreasing renal perfusion. The syndrome's onset begins with a decrease in urine output and rising blood urea nitrogen and creatinine levels, which is termed as azotemia. So this is what's happening in acute liver failure. Now we'll see what happens in chronic liver failure. So chronic liver failure refers to diffuse transformation of the liver into regenerative parenchymal nodules surrounded by fibrous bands. Okay, cirrhosis. What happens in chronic liver failure is cirrhosis, which means the normal liver parenchyma will be transformed into parenchymal nodules surrounding by fibrous bands. It is morphological change most often associated with chronic liver disease. The leading cause of chronic liver failure is chronic hepatitis B, C, non-alcoholic fatty liver disease, and alcohol-related liver disease. While cirrhosis is a common feature of a number of chronic liver disease, it is not a specific entity and is more important to recognize that not all chronic liver disease terminates in cirrhosis, and not all cirrhosis leads to end-stage liver disease. For example, chronic biliary tract disease often do not lead to cirrhosis even at the end stage, whereas patients with treated autoimmune hepatitis or cured hepatitis C may have adequate liver function despite the presence of cirrhosis. Okay, so this is not mandatory. Even in diseases that are likely to give rise to cirrhosis, the morphology and pathophysiology of cirrhosis in each may differ. Thus, while the term cirrhosis implies the presence of severe chronic disease, it is not a specific diagnosis and has variable prognostic implications. There are also some instances in which cirrhosis arises without any clear cause. The term cryptogenic cirrhosis is applied to such cases, okay, when cirrhosis arises without any cause. So here we can see gross appearance of cirrhosis resulting from chronic viral hepatitis. There are scarred areas, broad scars separating bulging. We have this bulging regenerative nodules which are separated by the scarred areas. Now, if we talk about morphology, cirrhosis is characterized by transformation of the entire liver into regenerative parenchymal nodules which are surrounded by fibrous bands. The nodular nature of the process is readily evident grossly also and microscopically. The size of the nodules, the pattern of scarring, whether it is linking of portal tracts to each other, means portal or linking portal tracts to the central vein. Okay, the degree of parenchymal loss and the frequency of vascular thrombosis, particularly to the portal vein, vary between disease and even in some cases different individuals with the same disease. As mentioned earlier, stem cell activation and differentiation give rise to duct-like structures which are called ductular reactions. This we read in when we were talking about mechanism of liver injury. So in chronic liver disease, what happens is these ductular reactions, they increase with the disease progression and usually most prominent in cirrhosis. Now, regression of fibrosis and even of fully established cirrhosis may follow disease remission or cure. Scars become thinner and more densely compacted and eventually start to fragment. As fibrous septa break apart, adjacent nodules of regenerating parenchyma coalesced into larger islands. All cirrhotic livers, they show elements of both progression as well as regression, with the balance being dictated by the severity and persistence of the underlying disease. Now, if we talk about clinical features, about 40% of the individuals with cirrhosis are asymptomatic until the most advanced stage of the disease. Even at late stages, they present with non-specific clinical manifestations such as anorexia, weight loss, and weakness. Eventually, signs and symptoms of liver failure, which we just discussed when we were talking about acute liver failure, and jaundice, encephalopathy, coagulopathy, and much the same as in acute liver failure. However, there are more significant additional features which are what? This is chronic severe jaundice can lead to pruritus or itching, which may be so severe that the patient scratch their skin raw and risk repeated bouts of potentially life-threatening infection. So due to jaundice, this pruritus happens, and pruritus is also seen in other disorders associated with cholestasis, suggesting that it is related to accumulation of bile salts in the body. Its precise pathogenesis is still unknown. Next up, portal hypertension can be there. It is more frequent and manifest in more complex ways in chronic liver failure than in acute liver failure. It stems from increased vascular resistance coupled with increased portal blood flow. The increased resistance to portal flow is at the level of sinusoids and is caused by contraction of vascular smooth muscle cells and myofibroblasts, and disruption of blood flow by scarring and the formation of parenchymal nodules. Increase in portal venous blood flow is due to arterial vasodilatation. The increased planktonic arterial blood flow in turn leads to increased venous efflux into the portal venous system, which leads to hypertension. So, other than this, there is portosystemic shunts which develop due to sustained portal hypertension. These shunts are produced principally by dilatation of collateral vessels. Most notably, venous bypass develop where the systemic and portal circulation share common capillary beds. The most clinically important of these are esophagogastric varices. So the varices will develop which arise in 40% of individuals with advanced stage liver disease and may be the source of massive frequent fatal hematemesis, particularly when there is associated coagulopathy. Next up is ascites, which means the accumulation of fluid in the peritoneal cavity, and about 85% of cases are caused by portal hypertension due to cirrhosis. The fluid is transudate, having less than 3 gram per dl of protein, largely albumin, and serum to ascites albumin gradient, which is this SAL, more than 1.1 gram per dl. Long-standing portal hypertension may also cause congestive splenomegaly. The degree of splenic enlargement varies widely, and splenic weight may reach up to 1000 grams, 1 kg, 5 to 6 times the normal, but it is not necessarily correlated with other features of portal hypertension. Splenomegaly may secondarily cause hematological abnormalities such as thrombocytopenia because of loss of platelets, or even pancytopenia because of destructions of the RBCs and all due to destruction of blood elements and by splenic macrophages. This condition is sometimes referred to as hypersplenism. Other than that, there is estrinogenemia due to impaired estrogen metabolism in male patients with chronic liver failure. It can give rise to Palmer erythema or reflection of local vasodilatation and spider angiomas of the skin. Such male hyperestrogenemia can lead to hypogonadism and gynecomastia in the male patients. Most chronic liver disease predisposed to development of hepatocellular carcinoma, which will be discussed in a separate video. So the course and severity of chronic liver disease with cirrhosis vary widely from patient to patient. Even in those uncommon instances in which cirrhosis regresses following disease remission, portal hypertension may persist due to presence of irreversible shunts. The most common cause of death are liver failure, as in acute liver failure and hepatocellular carcinoma. Okay, so this was about chronic liver failure. If we talk about acute on chronic liver failure, which means after years of stable, well compensated chronic liver disease, some individuals suddenly develop signs of acute liver failure. It could be due to hepatic insult that cause sudden decompensation of patients with chronic liver disease, including hepatitis D superinfection in those with chronic hepatitis B, or emergence of resistance to medical therapy in those with viral hepatitis, and systemic disorders such as sepsis or acute cardiac failure or superimposed toxic injury that tips a well compensated patient into with cirrhosis into liver failure. So means the patient was well compensated, stable, but having chronic liver disease, and due to some insult, superimposed infection, it develops acute liver failure. So here we can see all the signs and symptoms. The patient can have hepatic encephalopathy, then there will be malnutrition, there will be skin spider angiomata, there will be esophageal varices which can lead to hematomasis, and there will be hypersplenism, splenomegaly, which will cause pancytopenia. There will be portal hypertension, and here also there will be periumbilical spiders called caput medusa. There will be ascites and hemorrhoids, oligomenorrhea, amenorrhea, and sterility in case of females, and testicular atrophy in male patients. So these are all signs and symptoms due to cirrhosis. This photomicrograph here shows alcohol related cirrhosis. So we can see that there are thick collagen bands and they are separating the nodules. So this is the nodules and we have the collagen bands. Now in B, what we can see, this is after 1 year of abstinence, most scars are gone almost, and this is Mason's trichome stain. So this is the same patient, so which means after abstinence the scars will be there can be regression. So this was all about acute, chronic, and acute on chronic liver failure. Thank you.